So good evening, folks. Dr. David Rawson, founder and president of this academy. We're so excited tonight to be able to welcome one of our own, Dr. Marc Baltzan, who's on our advisory council and has been for many years and been a great support on the medical side, who is an associate professor at McGill University, the Faculty of Medicine. He's certified in respiratory medicine and a fellow of the American Board of Sleep Medicine. He's published research on sleep and respiratory disorders for over 20 years. He works in sleep clinics in Montreal and teaches at McGill University. And I know in the audience tonight are some Canadian dentists who work closely with Dr. Marc on a daily basis. And so he knows both sides of the fence. And so just such a wonderful opportunity to be able to have him to come with us. He's a busy man, but we do appreciate your time tonight, Dr. Baltzan, who's going to speak on sleep apnea, the sheer scale of the issue, and what we can do about it. Good evening, Marc.
Thank you, David. It's always an honor to speak, and I'm conscious this is a national endeavor. When we have a webinar, we never know where people are sitting, and I've been told that some people come in their bathing suits, although I have a tie on, because the pandemic's ending. I structured this like a formal meeting at a national conference. And one thing we have to do is show conflict of interest. So this shows anything I'm involved with at all with pharma here and bigger corporate interests, including the Federations of Medical Specialists of Quebec, FMSQ, which I've done presentations the past few years, and the Federation of Medical Omnipraticiens, the O is for general practice in Quebec, and the Order of Dentists. Just before the pandemic hit, I set up some paid video programming, which is a part of the essential educational updates that the Order of Dentists in Quebec has set out about sleep and sleep apnea. So that's it. The objectives, I wanted to sort of update what I consider this audience to be one of the best educated audience of dental professionals in the world. Because I've met Marie Markland from Sweden, who was one of the older ones around. I met some from New York. I met them from Texas, in the Mayo Clinic. And let's just say that those ones talk a lot finance when you sit around at a lunch table at a conference, whereas the Canadians want to help out. So it's a pathophysiology. I wanted to update on what the current thinking is from a respiratory research point of view. I'm I'm still a researcher, and we're doing a national prevalence study of sleep apnea to show before publication or pre-publication figures on a graph of the map of Canada and how often we find sleep apnea. And because there is a lot of sleep apnea, propose some strategies after some basic calculations for where I live in the province of Quebec of what's happening and what maybe needs to be done. Now we're coming out of the pandemic, but this is a webinar and we're all charged up and we're sitting at home being together. This is something that's a pattern that's happening. Children are now playing online. They look forward to their friends messaging them and going into their favorite gaming app. You may have heard of Fortnite, Halo, and others. There's a whole bunch, Brawl Stars, depending on the kind of money you have for the software. But this is the seed or a factor of obesity as well. The kids sitting around and not running around is a major factor of why sleep apnea is an increasingly popular problem. The major organ for breathing is not the lungs, but is the brain. And so this helps to understand why sleep apnea is such a problem. The brain is the seat of appetite, and likely when any genetics are done of obesity, they end up locating centers in the brain, the appetite centers really, and they're not that far from the sleep related centers, which are in the medulla, in the DRG, if you want, which is the primary output of the respiratory muscles, all of it in the kind of spinal cord that if it gets hit with any trauma or a bleed, you're dead. And the higher brain centers can modify it, but this is all part of the autonomic system. there's any problems in this part of the brain, it also can lead to central sleep apnea, which is a very small minority of all the sleep apnea out there, but you need to be conscious of it if you're going to be taking care of it. The pathophysiology basically means when things don't go right, when there's a problem, how does it work? Well, what happens with sleep apnea and obstructive sleep apnea, especially, there's a play, a to and fro of the breathing and the sleeping and the sleeping and the breathing, that when things are peaceful, everything's quiet, everything's rhythmic, and everything's stable. That stability is disturbed with, if now to cut it into two kinds of sleep apnea, where the central sleep apnea, there's something to do with the respiratory control, and it is not one kind of apnea. I'll get into that. Obstructive sleep apnea is now also being taken apart into several kinds. And I'm going to show the sort of the spectrum of the two kinds, which has to do with what's called loop gain. I want to bring that up now because it is a confusing concept. And I think if I give some time for your brains to catch on to what loop gain is, then that will be helpful, and you'll leave with some confidence and something to talk about with your colleagues who asked, "What'd you watch last night?" Sleep apnea isn't always abnormal. You can be seen to stop breathing in a normal situation. One of them is just simply falling asleep. The idea that has held the test of time for the past 50 years is when we're awake, we have a certain respiratory control, all centered in the DRG and other parts of the brain around it, that when we are awake, we have a set point to breathe with a little bit more stridor, a little bit more rhythm, a little bit more speed, and a little bit more ventilation. And then when we go to sleep, the set point of stability is a little bit lower, a little bit more relaxed, a little bit slower, a little bit less ventilation. And in that period of adjustment, it'd be normal to pause in your breathing. It's a central apnea, sleep continues, and everything goes fine. And then when we're sleeping, we can have a sigh. It is actually normal, or we can awake briefly and change our set points briefly and come back. Those also can cause an apnea in the adjustment between a normal control of one level and a normal control to another. And then in dream sleep, which in many ways has some physiology in like awake state, that during dream sleep, there's an active portion. That's the part where people's eyes are moving, and occasionally fingers will twitch. Occasionally people will utter a few words. And part of that, what seems like almost conscious respiratory control during the act of speaking in the dream world, we can pause in breathing while listening to whom we're speaking to in the dream. And that's also, to a certain degree, considered normal. So here is a normal central apnea from a polysomnography, where the top has a little bit of the brainwave and sleep monitoring with the eyes and the EMG. And then you see after about 2/3 of this window, a sort of squiggly line in the second line, which is the EMG. And that's the increased muscle tone with a brief waking. There's some movement. And so everything gets what I call scribbly. And that's part of the waking from a snoring episode. And there's this central apnea, where this, what looks like sawtooth in almost all the tracings in the lower half, just goes flat. That's an apnea. And that's normal, and that shouldn't be counted when it's being scored by a human being. The machine scoring will often add that in to the total. Pathologic central sleep apnea, and I have this old book from 1892 by William Osler. He describes Cheyne-Stokes respiration. This is something that actually, if you have an older patient who's had some declining health, and they're sitting awake in the chair in your dental office, you can observe it. Here they seem to be struggling to breathe, and then they stop breathing. And this can be done awake and asleep. And here, this Cheyne-Stokes respiration of breathing deeply and quickly and in a almost struggling manner when it's quite accentuated, because it's not always so obvious, but it can be very obvious, is that there's a cyclic nature that goes between 60 and 90 seconds, is that they breathe deeply, breathe hard, and then slowly come to an apnea, have an apnea, and then slowly increase their breathing again and again and again. And the causes listed by Sir William Osler, which still apply today, are, as he said it in the terms of over 100 years ago, fatty heart or heart failure, apoplexy or stroke, sunstroke, which is a toxic encephalitis here due to the environment, but all encephalitis can do it, tuberculous meningitis, which we don't see, fortunately, except in AIDS patients nowadays, and kidney failure to the point of dying, called uremia back then. And on a sleep study, you see the cyclic, rhythmic, stable, unstable nature of Cheyne-Stokes respiration. And now patients on treatment for obstructive sleep apnea may actually reveal this on what's now the downloads of the CPAP machines, which are monitoring all the CPAP treated patients every night and sending it off to their healthcare providers, who then review and see, oh, your sleep apnea index is going up. What's going on? It can be caused by a new cardiac disease. And if you as a dentist are treating obstructive sleep apnea with an oral appliance, and you're going to be using the new monitors that are coming available through several companies, and one of them already available for several years from Braebon, this may also come out if there's respiratory monitoring on the chip device that's in your device. So it's good to know and know if your device can tell the difference between Cheyne-Stokes respiration and really persistent sleep apnea. Another kind of central sleep apnea, I like calling it by its original name by the neurologist who described it, Dr. Biot from Paris, described this in patients with severe brain hemorrhages or tumors. And this is marked by central apneas, but with an irregular rate and irregular volume of breathing. So here you see the blue lines, each one's a breath. And this is a tracing from a home monitoring. And if you look at the oxygen saturation, you know sleep studies at all, the oxygen saturation is sort of running at 85. That's low. It's more like 95 normally. And the computer indicated one desaturation in this whole long desaturation of 83. And this is slow breathing, irregular breathing, and irregular volume. Every blue spike is a breath. And you see how they change very much from one breath to the next in no clear rhythm or order. And here, this is a 5-minute tracing, so there's not many breaths in 5 minutes. And this 73-year-old woman had severe arthritis treated with fentanyl on a patch. And she had hypoventilation in the daytime being investigated with this. The diagnosis here was the toxicity of her medication. And we all know what happens when you get too much fentanyl. There's also a much more rare problem where people can have non-restorative sleep, no snoring typically, and they turn out to have sleep apnea. But here there's a stable cycle, uncycle, apnea, breathing too fast, apnea, breathing too fast, which is not Cheyne-Stokes respiration because it all happens too fast. Typical Cheyne-Stokes is about 90-second cycles. Here, this is more like 45. And this happens, it's idiopathic. It's not known why. The treatment is see a specialist and he'll figure it out. And then individual patients tend to sometimes have no treatment. They've tried CPAP and often don't like it. But I do have a patient on oral appliance and it seems to help him sleep better. I can't figure it out. It doesn't make sense. And it took me 10 years to come to that because I wasn't sure anything was going to help. But this is an unusual form of central sleep apnea. Coming back to what's more common and what you likely are seeing most of the time is sleep apnea is 37 times more frequent than central sleep apnea when you look at the entire community of older adults in the United States. And one very well described cohort of the Sleep Heart Health Study showed that sleep apnea was actually quite frequent. And here, moderate and severe in a study where the patients were monitored around the year 2000 to 2003, if I remember right, eventually published 6 years ago. It shows that women, 12% of the time, had moderate to severe sleep apnea. That means 1 in 8 women. And men, 25% of the time. had moderate to severe sleep apnea. If you want to include mild sleep apnea, basically double these numbers. So that means including mild sleep apnea, women will be up to 24%, and men, half of them, have some degree of sleep apnea if you monitor them. Not all of them symptomatic, not all of them needing treatment, but that's a lot of people. So here I'm going to get into more of the pathophysiology, the cause. What causes sleep apnea? One answer is, one, a crushing upper airway. And that's a way of describing, without getting too scientific, when people are obese or have just too much flesh in the upper airway. So there's too much in the throat, and it could be tonsils in a child, tonsils in an adult, a really, really big tongue, which just can't stay out of the way when people are sleeping. Second option is there is the anatomy that's there, and they're not having apnea when they're awake. When they go to sleep, everything relaxes, and it relaxes too much to a certain degree of weakness to function properly. So that's the weakness of the dilator muscles of the throat. That's a second proposal for the cause of sleep apnea. And it's likely the explanation why it just gets worse with age. And the third is a twitchy sleep arousal neurology. This means that when people have any sort of little bit of collapse of the upper airway, that the arousal system that awakes a patient from a respiratory disturbance wakes them up really quickly, and they breathe or change their set points and either have breathing too much or an apnea, and they switch back and forth from a twitchy reaction to falling back asleep, and then a twitchy reaction and falling back asleep. Or what could be the answer? All of the above. Well, now that polls are unactivated, we can't actually all vote for here, but the answer here is all of the above. And I'm going to try to take this apart and make some sense of it in a way, because if you add an oral appliance, perfectly made, perfectly fitted, perfectly adjusted, and a patient well chosen, the oral appliance by logic works on the crushing upper airway by opening up the upper airway, adding a force forward along the jaw, maybe opening the mouth as well, depending on how you set up your appliance. It also may help weak dilator muscles by just giving more space for the collapse to happen. But it won't help the twitchy sleep arousal neurology, not if things are making sense. So the crushing upper airway is because some patients and some people have a crushing total body physiology, where not only their necks and their throats are being crushed by all the extra flesh from obesity, but also around the heart, around the lungs, and around the digestive system, and all the skeletal system below with crushed backs, very bad hip arthritis, very young, very bad knee arthritis, very young, and foot bones that have trouble walking. Upper airway collapse, if you look at it, could be also due to just simply a certain geometry of the anatomy where the tongue, you let go with the tongue and it becomes a cork, a plug. Another dynamic aspect that's been very well described now, and this comes from around 10 years ago in a premier journal for cardiologists, it's called Circulation, is that there is a certain amount of fluid we all have, and it generally hangs around in the body dependent with gravity. That means it goes down with gravity based on whatever posture you're in. So when people are in the daytime here in the diagram standing, but then they lie down, that fluid tends to, if you see the small arrows in the lying down figure here, the small arrows are redistributing the fluid that's within the body upwards, because now the body's horizontal and it goes into the neck and adds to the crushing weight of the muscles and the tissues of the neck. So the more neck flesh you have to begin with, well, this will add 10% perhaps by the end of the night as a slow diffusion process. And this explains why in the sleep lab, when I was training in the 90s, we would see that sleep apnea would just get worse and worse as the night went on. Well, here, the neck is getting more and more full of new or redistributed fluid. And that's only adding to the narrowness of the upper airway. So the simplest diagram of the forces of causing sleep apnea, if you imagine this is the tunnel, which is the throat and the upper airway all together, is there's a transmural pressure. So the circle is the wall of the throat. The P intraluminal, inside the tunnel, is the pressure that is passively there. It can be a negative pressure as long as the pressure outside, or the transluminal, is strong enough or well oriented enough to keep the tunnel open. And the transmural pressure, so that's the pressure that can sometimes collapse it or keep it open, is a simple equation of these two forces. But the dilators of the airway, and so that's the genioglossus to keep the tongue forward, and all the other pharyngeal and hypopharynx muscles, they add a force. And this is an area where the pharmacology is being researched to try to add some tone during sleep without disturbing sleep to the upper airway. Nothing's come out to be a perfect solution as a pill, but research may eventually find something for at least a minority of patients with sleep apnea, and it may be added to patients who have a partial response to oral appliances. This is why I bring it to you tonight. In the pathophysiology of sleep apnea, there's anatomy. We all know that. That's the easy part, and I'm not going to get into it too much. There's a sleep-related pharyngeal muscle dilator activity. And then there's the arousal from sleep threshold for respiratory stimulus. And that integrates with the respiratory control. So when people feel it unconsciously in their sleep, a choking sensation, which can lead to a hypopnea, not necessarily an apnea, that reduced respiratory benefit from whatever effort's going on is sensed by the respiratory control system. And some people sleep through it, but end the hypopnea or the apnea, but some people wake up and overdo it. And that ventilatory response, or the exaggerated response, is what you call high loop gain. If there's too much ventilatory response to a ventilatory disturbance, and the disturbance is the collapsed upper airway with a hypopnea or apnea happening, then that leads to some instability that is cyclic breathing and disturbed sleep. And the best way I can try to communicate this, and I've had some success now with the other doctors who don't like to learn so well and the medical students who are eager to learn, is to think of a canoe, because we're all Canadians and we've all at least been in one once. Sometimes we pay a lot for canoe, and many of us own canoes. So you're canoeing on a clean, flat, sunny day. The lake is flat, everything's fine, and it's actually quite easy to keep a straight line as a single paddler in a canoe. But here, then you add a crosswind. And what happens? The inexperienced canoer on the bottom line will overcompensate by paddling too much, switching the paddle in a late way after the canoe is swung around, and then paddle hard on the other side, and so zigzag across the lake due to a crosswind. That's all it is. A more experienced paddler will know where the canoe is going even before it turns, and switch sides and not overdo it. And so although there might be a bit of a zigzag in an experienced canoeer's trajectory across the lake on a little bit of wind in the day, it won't be the high loop gain like the bottom one with unstable and ineffective trajectory. And this is kind of an illustration of what a high loop gain system does. A very twitchy, overcompensating canoeer has high loop gain, and a calm, experienced, and not too sensitive to the wind canoeer can keep a better straight line and stability. And this is a typical tracing of a patient on polysomnography who has high loop gain, which can make up even a third, if you believe the researchers in San Diego who are publishing about this now, a third of patients with obstructive sleep apnea. Here it's marked by, now if you look at the bottom, the NPT is where you count your apneas, and you see that there's quite a few apneas where the lines go really quite flat. And the ones where the squiggle lines or the tidal volumes, the breaths, get to be sort of half of what the biggest are, that's a hypopnea. And there's a lot of apneas here. And typically the oxygen doesn't change very much because these people are so busy waking up to breathe, they don't let the oxygen go down. They may clinically have an insomnia, and they may persist in their obstructive sleep apnea with good therapy. I'm going to switch gears now, look into clinical outcomes. This is more a flyover. Some of you will know this quite well. What are the results of sleep apnea? Excessive daytime sleepiness, fatigue with non-restorative sleep, or hypertension? The answer again is all of the above. It's not just one thing, and sleep apnea patients are diverse. So here, to look at the symptoms, you can divide them into the nighttime symptoms. And here, this is what often the witness will complain about or be worried about without necessarily complaining. That here, grandpa always drops off after lunch. Well, that's a daytime manifestation, except bats are nocturnal animals. Anyway, not the greatest graphic. But here, the nighttime symptoms have to do with what happens during sleep, but also daytime symptoms. And any reasonable one-page questionnaire should pay attention to both. And why people are sleepy is not just simply the disruption of the sleep. It seems to be that there are several factors when you actually have sleep patients. Is that the top light blue box, short sleep time, well, that's happening to everyone in general compared to how much we used to sleep 50 to 100 years ago. The general trend that with all our devices and all our conveniences, that we actually do try to stretch out our wake time and only go to bed when we absolutely have to. We're grumbling that we have to stop watching our favorite season of whatever we're watching on Netflix and finally go to bed at midnight, then get up at 5:30 to do all the things that we have to do to pay our mortgages and our credit card bills. That's something to not ignore, because if you have a patient who you're treating for obstructive sleep apnea and they still say they're sleepy, well, then ask some basics. When do you go to bed and when do you wake up? And if this patient has an iPhone with an app, well, you can also check how much they think they're sleeping with how much they're actually sitting still and the phone thinks they're sleeping, or their Fitbit. That can sometimes show that some people think they're getting 8 hours when they're actually getting more like 6. Sleep disruption of any sort, not just sleep apnea, can do it. A good 20% of patients in sleep clinics with sleep apnea have depression at the same time, and that's a big factor that doesn't improve with all the sleep apnea therapies. Our patients with an older population, often with diabetes and hypertension, have medications that can sometimes cause it. There's even glaucoma medications, drops that can cause sleepiness. Obesity itself, that sheer mass of adipose tissue is hormonally active. And some patients are prone to sleepiness in proportion to their weight. And sleepiness much improves with drastic weight loss, such as after bariatric surgery. And we're seeing this in the post-COVID patients, that the inflammation with COVID and that persists in some unlucky patients after serious COVID infections. The inflammation causes fatigue and sleepiness, what seems like a post-viral syndrome, which we know well with mononucleosis from the past. Another issue, and this is the path to death by sleep apnea, is the cardiovascular disease that can come with it. And there's debate, and it's probably not all one size fits all here as well, but cardiovascular disease, if it's not caused in part by sleep apnea, it certainly is destabilized by untreated severe sleep apnea. And here, if there's been enough studies done, is that you can again and again link persistent or difficult to treat high blood pressure with sleep apnea that's untreated, cardiac arrhythmias, cerebrovascular disease, and heart failure. And here, although you can find that people who have those diseases then are found to have sleep apnea, and you may say, well, it's a whole ball of wax that goes along with obesity and poor lifestyle. Once people have been identified with or without sleep apnea and have treatment there, the incidence after identification and you follow these patients for a while really gives a pretty good idea of what is favoring or causing something else, because there you're moving forward in time. And when people don't have sleep apnea or significant sleep apnea, so here the AHI is 0 to 15, they're considered reference, because in a cardiovascular point of view, mild sleep apnea has really very little, if any, impact on cardiovascular health. Starting with moderate sleep apnea, there's a bit of a increased signal, almost a doubling of the chance of having a stroke. And then with severe untreated sleep apnea, it's 3 to 4 times more. And the confidence intervals go from well over 1 to even 8 times more, which that kind of degree has been found in other populations. Once somebody's on CPAP, they go back to the same level of risk that someone their age has who doesn't have sleep apnea. And this isn't just one study. This has been shown again and again and again. This is from a big network cohort from the very good respiratory research group that is the whole country of Spain. All the lung doctors seem to work well together there. Sleep apnea has also been associated with mortality. There, it's also not one size fits all. These are studies from way back when sleep apnea was still being sort of discovered and studied and what its place. But if you study a community of people where you know what's happened to everyone, if you come back and follow them on a long-term research, if people are at the age where they become at risk of cardiovascular disease, so generally starting at age 50, the relative risk, if they have sleep apnea, generally left untreated in these cohorts, is it increases their chance. Once you get to be so old, you're in a nursing home or a retirement village where those are all survivors, where the youngest people are 65 or 70, there's much less chance that sleep apnea is involved in causing mortality. That might be because of competing diseases. Alzheimer's is not a sleep apnea associated disease, at least as a result of sleep apnea, for example. But if you look and you study young people, so starting at age 30 or 40, there's a clear signal here from Sweden, with a whole community there surveyed for snoring and excessive sleepiness. They had almost an 8 times more mortality in the younger age groups, but it fades as an effect in older patients. And here I reanalyzed some data from the country of Israel. And there we found that the patients with sleep apnea, generally they're untreated because at the time CPAP was a very undesirable machine, and sometimes the equivalent of $5,000 for a citizen, not funded by the government. But you see here, the young 20, 30, 40 age group, they're the ones who have no competing causes to lead to mortality. But once you get into the 50s and 60s, there's other causes of mortality, and that might just drown out the signal or the problems that sleep apnea then render people vulnerable to dying of something along the way. And this is probably not accidents, car accidents, this kind of thing. These are mostly cardiorespiratory diseases that have recurrent admissions to hospital or just a big stroke. Sleep apnea is not just one kind. So I showed you from the breathing pattern, central, several kinds, and obstructive sleep apnea with a varying kind due to the loop gain. And the types, the floppy uppy airway where the dilator muscles are weak, or the simply crushing upper airway from anatomy and likely obesity. Looking at what people experience, how do they describe what they have? They looked at cohorts of people with sleep apnea, and the ISAC cohort is where they studied almost everyone in Iceland. And Icelandic adults, anyway, tend not to move to another country. Why? What other country speaks Icelandic? But so as a place to study a population that just never leaves, you can go back and go back and go back and find them again and again and look at the evolution of the disease, and you don't lose patients to migration or participants in their cohort. Well, here, all the adults that were studied could be divided into people who are somnolent or sleepy, people who complained that their sleep was just not good, interrupted, insomnia, not restful, but not sleepy as a result. And those with minimal symptoms, basically noisy breathers at night, either apnea, snorting, but they feel fine and they seem healthy. So this research, so I go back, published in 2018, generated another publication where the Americans said, wow, let's look at our cohort, the Sleep Heart Health Study. And they found that they could even divide the sleepy patients into very somnolent and moderately somnolent. There was a reason for that, because the very somnolent had an increased mortality that was like largely cardiovascular. Those with poor sleep and the minimal symptoms. Must say that the language in the questionnaires are different, which is likely why the pieces of pie are different sizes. In this study published in that same American cohort found that those who were, I'm going to go back, in the blue slice of pie came out, unfortunately, with a red line on this mortality graph. If you follow them for over 10 years, you find that there's a big separation in the curve. And about 60% of those are still alive if they're untreated patients with sleep apnea versus all the other kinds, who generally 70% or more are still alive, getting on almost 20 years later. So this is now, how big is this problem? Without showing a slide, we all know that obesity has been increasing since the 70s in Canada, and we're a few years behind the trends when it comes to the quantity of obesity of the United States. And the United States is not everywhere is the same. It seems that West Virginia is the leader for obesity in the states among the 50 states, and Hawaii and states like Hawaii tend to be the last. But it's a problem all over. And in Canada, we studied it and we found that in the 7 provinces where we already have just up to now good data, that the moderate and severe sleep apnea, if you can include it as the cardiovascular or the ones, the kind of sleep apnea that can lead to mortality, it's about 29% across the board. And there's a little bit less in British Columbia, and the reason seems to be less obesity in British Columbia. Another factor here that is a minor factor, but I don't want to, I think it interacts with obesity, is that we find a good half of people drink at least 3 times a week on a regular basis, which in my mind adds to the weaker floppy upper airway muscle dilator activity, because alcohol with its intoxication, 3 drinks is enough to increase or change category. If somebody has mild sleep apnea, if you do a sleep study after 3 glasses of wine, it'll convert to moderate. So I think this may also be a factor. What can we do to manage sleep apnea? Because this is a lot of people. The first thing is to talk about it. So you search about it, and I've seen some dental practices here in Montreal where I work that on intake have a sleep apnea questionnaire. They do not do oral appliances in the clinic, but they're identifying, and if they find something, they refer after a conversation with the patient. Then once a patient is considering that they might have sleep apnea, which is often something they've known about for a couple of years before any healthcare professional takes it seriously, is that they say, well, why would it be worthwhile to go through the big hassle of trying to do a sleep study and get some therapy about it? And the therapy is intervening. And then once you have some degree of therapy, is to verify that what you're doing is effective in one way or another. So if somebody's sleepy, you re-administer your sleepiness questionnaire, check their Epworth scale. For example, if they've had headaches, ask them about the headaches and document. The headaches are now so good they've never needed to renew their migraine medication since they've had an oral appliance. So that verifying is tracking your outcomes for the individual. So sleep apnea in a sleep clinic, the excessive daytime sleepiness, obstructive sleep apnea is the major cause. Some patients are referred for narcolepsy, but the chances of that are sort of 1 in 100, even in a sleep clinic. And that's where we see narcoleptic patients. And a lot of patients are sleepy, but it's not just the sleep apnea they have. It's also other problems. I bring here depression, and I've also brought up others. And then once patients are treated effectively, so you verify that they've had a therapy that seems to be worked and they're using it, it's not rare to find an excessively sleepy individual in spite of their effective treatment for sleep apnea. So let's say you have a patient with an AHI of 25. They opt for therapy with an oral appliance. You have another measure of sleep apnea afterwards, and the oral appliance has an AHI of less than 10, which I would consider in my practice to be sufficient response with an oral appliance. But then you administer the Epworth scale, and it was 16 before and 15 after. Well, you have an unmet need there. And that's where you refer back, or you find a sleep physician who can prescribe medication for the residual excessive daytime sleepiness, which if you have as many patients as some of the dentists I know in the audience, probably may not have been checking for that afterwards. And it's a little pearl that may be helpful for future practice among your experienced members of the audience. To identify it, there's several questionnaires that have been out there. I won't name them all, but this has stood the test of time, and it comes from Canada. Frances Chung in Toronto did this when she was a young anesthesiologist trying to find a way to effectively pre-op patients, because going to surgery and having severe sleep apnea untreated can cause problems afterwards. And this has become a very useful way to identify or stratify the risk or the likelihood of sleep apnea. And here, based on the score, which could be 0 answers, positive answers to the questions, 1, 2, 3, 4, 5, 6, 7, is the chance of having moderate or severe sleep apnea is the blue line. So if you have a score of 3, the chance is 35% if you follow the graph. If your score is 5, your chance of having severe sleep apnea is just over 40%. None of this leads to 100%, so there needs to be a test to confirm the diagnosis. Sleep apnea doesn't always have the typical symptoms of excessive daytime sleepiness. Some people sleep alone, they don't know they snore and haven't had anyone to witness an apnea. But when patients are waking up to empty their bladder 3 times a night, that's abnormal. Sometimes a man with erectile dysfunction that is unexplained otherwise. Some people get confused at night and start wandering around. And this can be because the sleep apnea is disturbing their sleep and perhaps provoking a pre-existing tendency to sleepwalking that they had only as a child before. There's also other dream enactment behavior, REM sleep behavior disorder, which is an unusual way for it to show up, but the more common reason is not a neurologic problem or early Parkinson's, is sleep apnea in the clinic. Night sweats even. I'm going to go quickly through this just because I see the time. We've done some studies in primary care. So we take the burden of care from the now model that a GP needs to send to a specialist who then decides, are we going to do a sleep study? They almost always do a sleep study. And we give the sleep studies directly to the general doctors. And we also add it with a questionnaire so that GPs may not ask a lot of questions, but they prefer if a questionnaire is functioning in the clinic, they can read through it quickly instead of having a long conversation, and it's time effective, which is why it's a big tool in clinics that adopt these kind of things. Here we found that when a GP's clinic allowed the sleep researchers to quietly hand out these questionnaires and take them back, and then when people had a questionnaire and they consented, they found that it was very common for men and women who accepted the questionnaire that they had symptoms of sleep apnea. And on average, when they had confirmed sleep apnea, there was an average 9-year delay before sleep apnea was clinically identified, before they had a prescription for a sleep study, you might say. And talking about the sleep symptoms is very infrequent. Pick any symptom here, and I'll list the symptoms because it's small writing perhaps on your screen: waking with a dry mouth, snoring, apnea or interruption of breathing during sleep, parts of the body jerk at night, twitching awake, you might say, falling asleep during the day when you don't want to fall asleep, or waking with a headache. If the symptom was present, you have a solid bar, women in purple, men in blue. And then if it had been discussed with any doctor anywhere along the way, you have the cross-hatched ones. And you see here, basically, people aren't talking about it. And then this led to a bigger waiting room study where older patients were approached in the waiting room in now not just one clinic, but 3 clinics. And they went through now a questionnaire that was called a checklist that was streamlined. and they were offered to continue to a polysomnography that was a low hassle scheduled for them. They didn't pay. It wasn't in the core healthcare system that was overwhelmed. And there's time in a waiting room in general practice, because generally people wait over an hour to see a scheduled appointment with a doctor, unlike I'm sure the dental practices you all run. And here, well, what is this process? Are we just screening everyone for no good reason? But the patients who showed up for their sleep study, or just simply accepted one and then eventually had their sleep study, are the patients who have symptoms. So anywhere there's a star, these people had a different amount, and those were depressed, and that could easily explain their symptoms. They didn't show up for their sleep studies often, but anyone who woke at night to urinate, or felt fatigued or sleepy, or had witnessed apnea, they were concerned and they were motivated and went through with it. So this is sort of filters out the patients who have a need. They have a symptomatic need. We're not just finding patients who have sleep apnea, who don't need treatment, who don't feel ready for treatment, are not going to comply, are going to perhaps waste time and money. These are patients, if you open it up to GP practices, it can function and it can sort of self-focus, and that those with symptoms will end up having a sleep study. And further part of this, which I won't show, is they tend to adopt and adhere to therapy. What do you do to manage it? You know that there's tests, home sleep apnea tests, which aren't paid for by OHIP in Ontario, but everywhere else they are. And they tend to be 3 to 1, the kind of tests that are done now in American and Canadian healthcare systems outside of Ontario. It's good to know the urgent criteria. If you have a doctor who works with you, urgent criteria include a truck driver, anyone who's got a big machine in their control, and pregnancy in someone who has obvious sleep apnea, because there are certain outcomes of pregnancy that are influenced by untreated sleep apnea, hypertension of pregnancy, and small babies being born without other explanation. So what if CPAP won't work? What can you do? Is it just oral appliance therapy? Maybe some people vote for that. Is it surgery? Well, ENT crowds tend to vote for that one. Is it physiotherapy? That's a relatively new and can be added to oral appliance therapy. Positional therapy, there's now validated Health Canada approved devices costing around $400 that can help improve certain patients with positional sleep apnea. Nutritional modification and exercise. All of the above is the answer here. Not hard to set up exams. My students like me at McGill because they tend to know what to answer. But all of these can help certain outcomes for certain individuals. But this is not one size fits all, and they can be combined. So oral appliance with surgery and physiotherapy and positional therapy can be a basket of care for a patient. And if they require nutritional modification and exercise because they're not doing enough to basically stay healthy, then that can be added too. Adherence for all the therapies could be a problem, but with CPAP, it's especially well known. So that's why the need for dentists across Canada will never go away. I won't get into this, but if you talk about exercise and nutritional therapy, a low salt diet is not to be underestimated. Remember that diagram with the body standing, the body lying down, and the 3 bottles. Well, here's a calculation from Quebec. How many health professionals could help? Because in GPs, there's 10,000 active GPs in Quebec, specialists, more than 11,000. Dentists in Quebec make up more than 5,000. And then there's allied health professionals, which work in the front line or with these to magnify the effectiveness and the capacity to take care of people of all of these health professionals, hygienists including, and dentists. And I didn't include psychologists, but they have a big interaction with patients with sleep disorders. In Quebec, they call respiratory specialists, who are the certified sleep specialists in Canada, pneumologue. That's my job title in French. There's only 282. So if you ask 282 and 275 are actually active when I ask the order. But in Quebec, Moderate to severe sleep apnea affects over 1 million patients. You can't ask 275 doctors to take care of 1 million people. It's just not possible. So this is a big, easy calculation that says we have to involve many more people in taking care of sleep apnea, and leaving it to the specialists as a certain kind of territory, I think, is outdated. To handle this, I'm doing it right now as education with all of us, but I'm preaching to converted here. I'm also working with general practice, and that map of Canada will be in a publication, and there 92% of patients with obvious sleep apnea on questionnaire, high risk on the stop bang score, didn't have a diagnosis of sleep apnea across Canada. So this isn't just a one province issue, it's all over the place. Discussing it with patients helps to motivate them to seek care and to try to find ways of managing it. And the healthcare systems probably have to change. And if they don't change, the private system is going to take over for them because there's a market there. The pandemic has helped by increasing the reach of specialists and other doctors with the telemedicine, which dental practices have trouble doing because dentists need to be into the anatomy. But telemedicine has increased the scope. I'm seeing patients who come from much further away who are nowhere near any of the known sleep labs in Quebec.